So I just wanted to let you all know that, of course, you know this is being captured on video, and these discussions will be available online in an edited version that we can, of course, make available to you. There's also a plan to capture the ideas that have been presented here into a workshop summary that will not, in a sense, make any recommendations or describe any consensus findings, but be available to you all in the near future and in the community at large for further dissemination of the ideas that were expressed here. And you know, this final session is kind of meant to wrap up and kind of provide ideas for agendas going forward for the field.
Thanks, Rebecca. So, as I think we've reiterated several times, we're not invited to make specific recommendations about what should be done in the military health system. But given that we, from the first wave of the IOM report, that we identified lots of different levels of evidence for different treatments, and probably none that was so strong that we're totally happy with it, even if we wanted to make recommendations about here are the effective treatments that you should implement tomorrow, we wouldn't know what to recommend. So for that reason, we structured the workshop to do a few things. Number one, a number of people coming into the workshop expressed sort of frustration about why aren't we farther along. I mean, there's a long set of answers to that question, but we hope that participating in discussions about what farther along would look like has, for one thing, helped you understand to some degree why we're not farther along. It's a pretty darn complicated scenario with a lot of steps and, of course, with resource needs. But we hope that bringing together people from the DoD, the VA, and civilian worlds who are all interested in this issue and this process will generate a certain amount of coherence about how we're thinking about it, what we view as the obstacles, what we might view as the solutions. Now, there was a lot of, well, we were kicked off with a concern, of course, about cost. Typically, we like to think about cost effectiveness, and without really good measures of effectiveness, it's hard to balance cost, and there's a risk, obviously, to saying, well, whatever minimizes cost, that's the best thing when you have no idea what the trade-off for that is. So that's a problem that we can't solve today. Because cognitive rehab therapy, as we described in the IOM report and as we've talked about throughout this workshop, isn't a single therapy, it's also not going to have a single answer to how well does it work, who does it work for, et cetera, et cetera. And that, of course, makes our collective job more challenging. One of the things that the IOM report found was that there was a relative shortage of patient-centered outcomes in the reporting. You know, I think one could argue that patient-reported outcomes don't become so important until you are pretty sure that there's some efficacy at all. But clearly, as we move forward in that sort of maturational frame, that should take on increasing importance. What I wanted to do now is just introduce some options that the Hillary and Mary and I talked through that are just meant to start the discussion, because I know even though we can't make recommendations, you want to think about what practical directions are available. So I'm going to throw out some initial things, and then I hope this will launch a vigorous discussion of what you will individually want to implement, what you will want to advocate for within your environments, and so on. So if we can have, oh, we do. Okay, so options for moving forward. So I'm going to take us from, actually, let me back up a second. So I'm going to take us, we're dealing with, on the one hand, a clear message from lots of you, I wish we had treatments to put in place tomorrow, right? And then we have at the other extreme, I don't want to implement anything unless I'm really, really sure that it works and is worth the money and is highly effective for lots of people, blah, blah, blah. And there's a continuum between those 2 points. So what I'd like to do is essentially look at what would be involved in implementing strategies that reflect that continuum, if you will. So one option is we say we can't wait. We have got to implement things starting tomorrow, even though the evidence is less than sufficient, okay? Well, what would that imply? First of all, it would imply another way of cutting what we want to implement versus what we don't want to implement, other than 3 asterisks, because we don't have 3 asterisks to use, right? That could be some combination of moderate evidence. We want 2 asterisks. We'll settle for 2 asterisks. But it could also, of course, involve weighing magnitude and importance of the problem. So, you know, you could find that the most solid treatment that we have evidence for today is something that a very small proportion of the military population has, and then that might not be the thing that you want to push forward, even though it's the most trustworthy thing you have. You might sacrifice. There's a trade-off, in other words, between these 2 things potentially. Now, I would argue, and I think this has come out of a lot of the groups, that relative standardization and operationalization of things to be implemented is still desirable, even if you don't know that the thing you're standardizing is effective. Why? Well, one of the things that we had a heck of a lot of trouble with in our IOM committee was defining what it was we were evaluating. So if you don't know that 2 therapists are doing the same thing, you can't even begin to talk about, is it effective? What is effective? So I would argue that there's a value to nailing down and documenting what you choose to do, even if you don't know it's a good thing to do, because it provides a platform for discussions about that question. So if you agree with that, then you could think, well, we want to either focus our initial implementation on things that are already manualized to that degree, of which we see at least a few. Again, it depends on whether those are the clinically important issues that you're dealing with. Another sort of maybe level down from true manualization, you're probably aware that there's now a cognitive rehabilitation training manual that is published by the American Congress of Rehab Medicine. There's a training program associated with it. If people are interested, we can talk in more detail. My understanding is that really isn't at the level of a manual that, as we've seen in some of these other domains, i.e. that it would be hard to say the specific behaviors that you'd expect to see from a therapist doesn't lend itself quickly to measures of adherence and fidelity and stuff like that. So, but it's available. One could consider implementing a training program guided by a standard curriculum, and then looking at, and then hoping that that will more standardize things. I would argue that if you go that route, probably some more homework needs to be done to nail that manual down a little bit more in terms of what you'd expect to see therapists really do. Okay, what's the advantage of doing those when you don't even know that they're effective? Well, first you can assess consistency of delivery. So at least you know that patients are getting the same services under the same name and the same billing code and whatever. But secondly, once you have a thing in place that you know is in place, you can systematically modify pieces of it. You can say, you know, we're getting a lot of feedback that this part of the curriculum isn't very helpful. Let's compare that to this other piece. Switch a piece out, switch a piece in. Can't do that if you don't know really what's already being done and what you're pulling out and what you're putting in. Okay, so that's the most sort of immediate and the least research-intensive version, though it's not devoid of some homework. A sort of middle ground is to think about implementation with a quasi-experimental health services design component. So here what I'm talking about is you still have to do the things we talked about on the last slide. You still have to decide what you want to implement based on some combination of existing evidence and clinical importance. You still have to standardize and operationalize because you're going to need to study, and what are you studying? But now the thing that gets added here is an attempt to design the most rigorous quasi-experimental design for capturing the impact of implementation. Because if you implement any of the things I talked about in this last slide across the board all at once tomorrow, and then say, how are people doing? You know how people are doing, but you don't know what that implementation contributed to how people are doing, because you don't have any design to tell you that. There's a lot of room to talk about the designs that could do that, and I'm just going to throw one out, but it's still a complicated problem. One way to think about it would be to, given the treatment approaches that you want to implement, what are the outcome measures that you would expect to show the effects of that implementation, thinking about the way we talked about outcome measures the last couple of days, i.e. you don't want to say return to work if you're implementing a memory retraining strategy in a heterogeneous population, because that would be a stupid thing to expect to change dramatically, right? So you have to know what you're going to implement, have predictions about the impact it should have, and put in place up front before implementation those outcome measures in your system. Then you could, for example, implement in a staggered fashion. If you were doing the training manual, it's going to take time to train people and then maybe come back for tune-ups, You could do that, a third of facilities this year, a third of facilities next year, a third of facilities the year after, while collecting outcome data throughout. And then you have some ability to look at whether the phasing of impact seems to match the phasing of implementation. So that's a staggered implementation or multiple baseline across facilities kind of design. You also, of course, need the characterization of the patient that you think might be relevant to the size of that impact, because it might differ from facility to facility. You want to be able to make sure that you're looking at implementation, not patient variation. And then the most sort of research-heavy and conservative, if you will, approach with respect to the evidence is to fund or seek funding for smaller maturational studies, to basically say, we don't want to implement things unless we have stronger evidence than we do now. We want a program to grow things to that level. There are things all along the continuum right this minute. It involves choosing ones that you think are worthy of further development. And as you do that, figuring out ways to encourage explicit attention to what those ingredients are, to early documentation in very clear ways, so that we don't have to figure it all out by inference after all the research is done, but it's really given clear thought up front. And then as we get 3 asterisks coming out the other end, we implement. I would personally argue that even if you go that more conservative route, that's not instead of health services research, because you're still going to acquire that 3 asterisk evidence in relatively constrained, tightly controlled studies that won't translate automatically to heterogeneous population, lots of different clinicians. So it seems to me you'd still want a kind of a health services overlay, such that as things get implemented, you look at, are we getting the same kinds of impacts in everyday clinical practice that we got in our studies, and if not, can we problem solve around that?